Dr. Stephen Merlin.
Thank you very much for your patience in remaining to listen to me. I certainly appreciate it. I looked up the word conflate, and it means to bring together. The second definition was to confuse. I'm a physician with 34 years of experience treating addiction in South Carolina. I've taught addiction at both of the medical schools. I am profoundly saddened by the anti-intellectual discourse that I heard today. With apologies to Morris Albert, feelings are nothing more than feelings and aren't science. Let's talk about edibles and smoking. You can't smoke it. You can't ingest it, because of course we don't call Percocet edible opioids, we just call it Percocet. So if you can't ingest it, and you can't smoke it, and you can't rub it in because it's an oil, how are you supposed to get it into your body? So that argument doesn't seem reasonable. You can't make a cannabis pill. It has to be in a caplet, an oil, and it's a very expensive thing to do. That's why only Big Pharma has done it since 1980, when Merlin was approved by the FDA. So you put it in an edible. Are you going to put it in broccoli? No, you're going to put it in something people want to eat. Okay? I'm not about advertising it as colas, but let's get off the idea that somehow edible is terrible, because it's got to get into the body to work. And you can't rub it in, and you can't smoke it, and you can't eat it, it ain't getting in. I wonder why physicians are now deifying the FDA. We do anti-FDA things every day. It's called off-label prescribing. If you prescribe a drug for a reason that the FDA has not approved, well, that's off-label. It's done all the time. In psych medicines, antidepressants are used for sleep. Okay? Blood pressure medicines are used for anxiety. Blood pressure medicines are used for opiate withdrawal. They're not FDA approved. That's false. That's absolutely a straw man. And by the way, if you're concerned the concentrations are too high, take less. Beer is much less than grain alcohol. So I would suggest not drinking 12 ounces of grain alcohol if you just want a beer. So that's, again, another anti-intellectual argument. I don't understand why violent crime from sinister, evil people are conflated by certain members of the community with medical marijuana. How does mass murder and medical marijuana come together? Only in the minds of some of the antis who've made public statements to that effect. And for once and for all, can we stop conflating drug use in medical treatment? Talking about adolescents getting schizophrenia from smoking pot is another subject. We're not asking adolescents to smoke pot. It's not like adolescents will go into daddy's drug cabinet, see Percocet, go, you know what? I'm not going to take that. Most of the marijuana that will be prescribed will be in substitution for other medicines. If you have PTSD, you're on a benzo, you're on an antidepressant, probably on an antipsychotic, and you feel like a zombie. Those people are impaired to drive. Look at all the opiates. Look at the psych medicines. They all say, do not operate heavy machinery. So it's not like we're taking a population of well people, inflicting marijuana on them, and put them on the highway. If you shouldn't drive taking your Zyprexa, or if you shouldn't drive taking your Xanax, and you get put on marijuana, it's the same, don't drive. So it's, again, another sort of false argument. I guess the thing that upset me the most, in 2002, I saw that there was an opiate problem coming. My hospital was full of people from Myrtle Beach, and I live in Columbia. There's a problem. So I wanted to open up an opiate treatment center. I was taken to court. You know who was on the other side? The 301 system. Got a buddy in the upstate. Same experience. What'd they tell Deotis? What'd they tell the administrative law judge in a subpoena? There is no need for this. We got the problem under control. And besides, the treatment is dangerous. What about the children getting their hands on methadone? Of course, now the 301 system prescribes methadone, prescribes other opiates, addicting opiates for the treatment of opiate dependence, buprenorphine, and it's all good. But they said the exact same things they say about marijuana, they said about opiates. They actively impeded arranging opiate treatment in rural communities. This is just a fact. And we're going to listen to their opinion about this. And I don't understand how the National Academy of Science is a poor source of medical information, compared to law enforcement, social workers, and lay citizens. I have tremendous empathy for addicts. I've been treating them since 1985. I understand the stories these people went through. Medical marijuana is not going to put Johnny on heroin. If little Johnny wants to smoke pot, he doesn't have to break into Dad's medicine cabinet, which makes Dad an irresponsible parent. He just has to go to school. And the edibles, showing up at school is a bad thing. But every few years we hear about LSD and the little tattoos for children. It's never actually happened. It's just an urban myth. Will there be bad outcomes? Yeah. Are there bad outcomes now? Yeah, it's life. Life is hard. But depriving sick people from medicine because of straw men, like, oh, it's edible, or it's too strong, or the FDA, or repeating the same tropes about what about the children? It's just very sad. And I appreciate y'all listening to all of this. And Senator, I share your compassion towards both sides. And I understand law enforcement has a job to do, and I understand some people are scared. But the reality is people are turning to much harder, much more toxic compounds right now. Doing this since 1985, been in the state since 1988, I really don't fear for my well-being because there'll be medical marijuana. I don't feel like my safety is reduced. I feel like my safety is actually enhanced. And I really appreciate y'all waiting to the ultimate last hour to hear me. Thank you very much.
Dr. Merlin, talk to me a little bit more about off-label prescribing. I mean, and this is prescribing, and they're not FDA-approved products?
Oh, sure. Let's take the classic example is Neurontin, gabapentin. Pfizer said, you know what? We didn't run any experiments to prove that gabapentin works for anxiety, but why don't you doctors try it? Now, a lot of doctors did, including myself, and for some patients it really works. Now, Pfizer got in trouble for advocating off-label use, but it's done all the time. I'll give you the most common one I can think of, trazodone. It's an antidepressant no one uses. Take it for sleep. It has no FDA approval for sleep. It's just given for sleep because it puts people to sleep safely, safer than Xanax. Clonidine, it's an old blood pressure medicine. It's used for opiate detox. There's tons of evidence that it works, but there's not an FDA approval for it to work. Because once a drug becomes generic, who is going to spend the millions to get FDA approval as opposed to perhaps 50 or 60,000 to run a decent study to show that it really works? Nobody. Because if you spend all that money, some other companies just to make that medicine for pennies. So once a drug gets to be generic, there's not going to be a lot of, who would spend that much money to do all these things on marijuana? Only the government can do that. It's not a drug company going to do that. It's generic. So you really, it's a very, birth control pills for acne. 14-year-old girl, terrible disfiguring acne. What are we going to do? We're going to treat her with birth control pills. Do you think the birth control company, the company that made those birth control pills, didn't line up 100 girls with acne, give 50 birth control pills and 50 not, and do a study and report on it? Dermatologists know what causes acne. They know how hormones work. Ergo, 1 + 1 is 2. It's not FDA approved. We have Marinol. People say, oh, the FDA would never approve THC. Yes, they did in the 80s. Right now, Senator, I could write you a prescription for Marinol and tell you it was for bad breath, as long as I warned you that it was off-label. Now, that would make me a very good physician. But if you came to me with neuropathy, you said, Doc, I'm done with opiates. Gabapentin made me crazy. Lyrica made me want to kill myself, just like they say on TV. I could prescribe you Marinol and tell you how to take it, and no one would care. But if it's the same substance that I recommend that you get from a pharmacy where like this complex isn't making a lot of money, and they're different people going to make a lot of money, then all of a sudden it's a bad idea. But it's done every day in every field by every doctor that's written more than 10 prescriptions has written an off-label prescription. And for a physician to recommend marijuana, it's just off-label. If I say, take these birth control pills, honey, it's going to help your acne. Prove it, doc. Well, I can't. Does the FDA say it's safe? No, the FDA hasn't got a word on this. So that's what off-label prescribing is.
I'm going to ask your perspective on, you talking about cultural change. Wait a minute. Maybe it was the pharmacologist
Well,
from the
I have
lab.
opinions on cultural change, sir.
Well, I'm trying to remember who said what, but I'm going to ask, what do you think is driving, one of the presenters did mention the bandwagon. I take exception to I don't agree that I don't want to prejudice your response. What is driving the perceptions specifically to medicinal cannabis?
I think-
Just right here, not even the rest of the country. In South Carolina, if we were to poll it, and I haven't seen it, but I try to stay in touch with my constituency. And I don't see, you're the medical professional. What is changing people's perceptions about medicinal cannabis?
I'll tell you my personal story. I give a talk to all my patients 3 times a week. Everybody I admit to the methadone clinic. And prior to a couple of years ago, I say, oh yeah, medical marijuana is just great. And the next time you go to the dentist, don't take any Novocaine, smoke a joint, make a joke, because I thought it was all California hippie nonsense. Then they came out with this National Academy of Science compendium of, we looked at thousands of articles and we've come to conclusions. It doesn't work here, it works here, it works here. And they gave the references. And I started reading, taking 29 hours of continual medical education on medical cannabis. I don't think anybody else up here was talking about how much education they had in medical cannabis. They were talking about how much they didn't like it and how dangerous it was, not how much they read. Okay, so that's the fundamental thing. What's going on with me is it works. Who am I to argue with the National Academy of Science? So that grossly changed me. So I think in the state there are 2 things. There are patients that are becoming aware. There are people who are frightened of opiates, because if you're not frightened of opiates now, you're asleep. And that's pushing, and I think what's pulling are monetary interests. And I think what's pushing against is also monetary interests. So I'd like for them to cancel out, and let's focus on the patients who are pushing the issue forward. Because there is big money pulling it, and there's big money pushing against it.
All right, well, I'm in agreement with you that there's greater awareness on a personal basis, either a family member, friend, just more awareness, and I believe it's predicated on more, it might be experimental, but there's more awareness rather than less. And of a matter this polarizing, I don't think people jump on bandwagons with less familiarity rather than more. So I guess what do you, within your profession, now you've heard numerous, there's physicians here today, MDs, spoke both as proponent and opponents. And I know it's not monolithic within the profession. Nothing is. I mean, this is the practice of medicine. We had that discussion 3 hours ago about the FDA as the end-all, or the aggregate of information shared within a profession. Where are we in 24 months?
Where we're going to be in 24 months, I hope, is having a really good dispensary system and relieving the suffering of those in South Carolina, assuaging the fears of law enforcement and others. If we don't, we're going to be surrounded by medical marijuana. We're going to be on an island, and that is actually, to me, more troubling, because then you are only going to have illicit use.
I should have been more specific. Where are we within the profession, regardless of what the public policy is or the law?
I like to think of my colleagues as medical doctors who are smarter than me and wiser than me. And the older I get, the less smart I get, and the wiser I become. I think there's a lot of people who are really hung up on the dose, who have these sort of concepts that if I put the pill in my mouth, all of it gets into the bloodstream. They're going sort of by the book without 30 years of clinical experience. So I think there are people who are going to be anti because they haven't read. The president of the SCMA is a gastroenterologist that's gone on record of saying there's no evidence that it works. You Google THC and gastroenterology and you pull up 100 articles this year. I mean, if you want to know about this, Massachusetts Medical Society took 22 hours of CME from them. I learned a bunch about it. But it's not something that a gynecologist is going to do.
Where'd you take the other 7 hours?
4 were New York, and the other 3 were just random companies that offer CMEs.
So those CMEs and they were credited towards your South Carolina
You betcha.
license renewal?
Yes, sir. Medical
So-
Society of Massachusetts.
So maybe there is an impulse, maybe there is a current, in my, and I'm asking, there's 2 forces here. You're talking about the one pulling, pushing, negation, and then the patient experience, which goes back to this what we call the sanctity of the doctor-patient relationship. This evolution of thought within the profession, because I believe that Will Rogers said that he could trust the minister and the veterinarian even more than he could trust the physician, because the veterinarian couldn't ask the patient to self-diagnose. But still, I'm driving out the trust that we put in the physician. It's only going to come, even if there was neutrality or more neutrality within the traditional structure of law enforcement, until the medical community, I'm not saying speaks with unanimity, but has the allowance of the practice of medicine.
Senator, when I came to the USC School of Medicine to teach addiction, the requirements for the Department of Internal Medicine are 0. The departments for the family practice was 4 hours of lecture for over 3 years, so 12 hours of exposure. Pediatrics had about 4 hours of exposure, and psychiatry had a month, but only because I was there, because before that, they had a few hours of lecture. I've been doing this since the 80s. I got a grant from the feds in the 80s to try to get medical students taught, residents taught about addiction. The universities don't want to do it. The medical students don't, they come from our society. They grow up with the same prejudices that addicts are bad people, and if they just pull themselves up. And then when you get to the psychiatrists, they don't want to be addicts, because in training here in South Carolina, the Department of Psychiatry, a mile away, would not allow their residents to have addicts in their residence clinic. If you said, I'm using cocaine, I'm very depressed, they wouldn't treat you. You said, I'm just very depressed, they would. So even the Department of Psychiatry isn't going to allow the residents to have addicts in their training clinics. So the fact that most doctors don't have learned opinions about addiction hasn't surprised me since 1985, when I started trying to teach doctors and take care of patients. And I'm not making that up. This is all factual. It's the least schooled thing. And we talk about, 10% of the population, it affects this. We all know that. It's not sexy, it's not glamorous, it's just not taught.
Senator Anderson.
Thank you for being here, Doctor. Your approach seems a little bit different than the doctor who was in here this morning from the Bronx, in terms of how you might approach this, or maybe you're already doing this. I don't really know. I think, our standard understanding of medicine, if I go to a doctor and he says, well, you've got this condition, so take a certain amount of a certain drug for it. This is what I'm prescribing. Okay? That's what I have lived with my whole life now. I'm pretty fortunate I don't really have to take too much unless I play basketball, in which case I better take some pain pills. But it almost seems like you're saying, and I want you to correct me if I'm wrong, that this approach is, you got a condition, so go to the dispensary and buy some stuff that you're allowed to buy with this card, and then go home and experiment and try things and see how it works for you. Now, you can correct me if I'm not describing that properly, but can you not see that approach A and approach B look vastly different to just a normal person looking at the process of how medicine and drugs work?
Oh, absolutely. And I think some of it is the doctor tells you to put heat on your elbow, doesn't tell you how many minutes, doesn't tell you how hot, and doesn't even tell you where on your elbow.
Usually, actually, they do. If I injure myself, he'll say, put it on for 10 minutes and put cold on and vary this back and forth. I mean, they,
Okay, and you look at, there's no research that says 10 minutes. I mean, that's just, so there's no research that says 5 minutes or 15 minutes, but it's heat, so it can't hurt. But what I am saying is that a lot of what we assume is just awesome medical practice, like, I don't know, taking an aspirin every night to prevent heart attack, which sort of came out a couple weeks ago, that may not actually do that, despite the fact that there's hundreds of millions of us taking aspirins every night. A lot of medical practice that seems so certain, when you look behind the curtain, it's really kind of like everything else. Like, a lot of law practice isn't exactly what you think it is. You go to a trial and it's not really what you expected. So I don't think a good physician would say, go get some of it and try it. Good physician would say, you know what? Let's try the smallest dose, so they only have 5s there, so cut them in half. Let's try 2.5, and you come back in a couple weeks. Now, that's what I would do. If the patient is severely disabled, I understand that's a hardship, but I personally would follow up, and I always start low and go slow. My methadone patients hate me for it.
and I can appreciate what you're saying, and I'll just talk a little bit if it's okay, trying to process how this
Sure.
works. This bill, I think the way it's written is, we'll come back in 3 months. Okay, so here we're talking about someone who's going to go home and cut up a little piece of a brownie or candy bar or whatever it is and start experimenting, self-medicating is what I call it. And the bill says, well, come back in 3 months and tell us how that's working out for you. I rather like the approach of, well, call me in a few days and then come see me in a few weeks.
Yeah, and I think most
Because
doctors
we're
would.
talking about something where, what I'm gathering, you're just not saying, go try this. I mean, you're going to suggest amounts and stuff based on your practice and your experience, but it's a little bit more of art than science is what I gather.
I would agree completely, and if you look at the State Practice Act, it's really kind of minimal. And I would hope that most physicians exceed the standards of the State Practice Act. So the bill requires a 3-month follow-up, but again, these are sick people. These aren't well people who are just giving a little marijuana so they feel better. Someone who's got Crohn's that's refractory to other treatment or doesn't want to get lymphoma from taking Humira. Someone that's got PTSD and doesn't like the 4 psych medicines they're on. Someone who's got chronic pain and is just not getting relief from yet more morphine, but now they got to go to the doctor 20 more times a year to get the same dose of medicine because of the rule changes. Those are the people that we would be talking with, and those people need to be followed up more often than every 3 months. It just wouldn't be good practice to start anybody. And I understand disabled people have a tough time getting places, but you wouldn't start anybody on a brand new medicine and say, well, kind of come back. Now, insulin has done that all the time, on the other hand, Senator. Insulin has done, you know what, get this insulin, check your sugar, and if your sugar's like this, take this much insulin. We assume that you know how to use the meter, and we teach you how to draw it up. So we let patients make decisions about their insulin on a daily basis. No doctor has a problem with that. You educate the patient. So you just educate the patient. What this bill to me is, these are the minimum standards. As physicians, we should do better than what the lawyers think we should do. So I wouldn't wait 3 months. Personally, in my practice, though, I wouldn't fault another judge.
Well, I can understand that, doctor, and I appreciate your engagement with the patients. I mean, the reason we're trying to draw a conservative type bill here is, ain't all doctors who've been doing this like you. Some of them are, if people refer to other states as the Wild West, there's a reason for that.
Absolutely.
There's a reason that, some doctors just write a prescription for anyone who comes in and says, my back hurts, and here's your card, go get some stuff, see you later. So I understand, you're in it for the healing purpose. What we're trying to prevent is something that doesn't look like that. It's just a gateway to let people get marijuana who want marijuana. Now, I want to mention something that I've asked a few people about today, because I don't know where this is going to end up going, but I have substantial concerns about saying you can get 2 ounces of marijuana every 14 days in leaf form. We'll just trust you're not going to smoke it, okay? So if we write that out of the bill, you can't get this in plant form. Do you think, well, that just makes the bill a waste of time, a failure? I mean,
No.
people are going to use this, as I understand it, some kind of oil that you take it in a tablet or a pill or something, or they're going to vape it, or these edibles. Is that what we're talking about is on the table if the plant form is off the table? If smoking is off the table, and it's off the table by the code, I mean, by the way it's written anyway, then how are people actually going to be getting this in their system?
Like I said, if you can't inhale it and you can't swallow it and you can't rub it in, it's not getting in your system. So I'm not a fan of smoking as a drug delivery system. I think that's just abhorrent. It's smoking. Most of what's in marijuana is not helpful. It's just plant material. It's no better than tobacco. However, you can very easily do what's called vaping with leaf. You put it in a machine, it heats it up to whatever it is, 310 something degrees, and it will vaporize the THC without burning the plant material, providing
What
a
about
different
vaping with
experience.
oil? Can you vape with oil?
Sure can. It's more or less the same process. You have a substance that contains, it's an oily substance. It's the nature of the chemical. You put a little bit on something glass, it plug it in or whatever you do, it heats it up, you inhale the vapor. There's no carbon monoxide with it. There's none of the tars and none of the other bad things that happen when
I
you
guess
smoke.
I'm saying, is it just as effective for what you're trying to accomplish as vaping with the leaves?
Well, yeah, actually it is. And vaping would really only be used for like an acute attack, like the poor woman with the trigeminal neuralgia. Bunsen burner to the face is a very accurate description. If she took something by mouth, because I'm just going to try to stay away from the edible word, took something by mouth, it takes an hour and a half to kick in. We heard this from the forensic guy. Okay, she's suffering for an hour and a half, really suffering. So why can't she vape some, get the instant relief, take the edible, my episode's over. So I see vaping as only for acute use, for people who are having immediate issues, and otherwise, take it in some sort of oral form, whatever is the least expensive, easiest way to transmit it from the company to the person. I don't care if it's in gelatin, which people call gummy bears, or whether it's put on something, it's got to get in your mouth.
Appreciate the commitment to proper nomenclature. There's so much pejorative out there. That is one thing that I would like to try to encourage senators going forward, is we just zero in on some real, besides trying to tamp down on the emotional aspects of this consideration, we just get down to, it goes right back to growing up as a child and trying to put, I guess growing up in a veterinary community, I was taught to describe bodily parts and functions exactly as they are, and don't get cute with it, because you get cute, you confuse people. And I think to call this, because this delivery system is critical to this debate, because our culture is so anti the traditional perceptions and the traditional practices on the recreational side. So,
Just follow up on Senator Anderson. So the rubbing part, the oils that you actually assume if you've got knee pain, you would rub it on your knee. I mean, is that
No, sir. It's not a local anesthetic. It works not so much in chronic pain, like if I fell and broke my wrist. I don't. It doesn't work for chronic pain. For acute pain, it works by disrupting certain parts of the brain that give the chronic pain response. You and I could have the same chronic pain, traumatic amputation. One guy's going to be tough and have no problems, and the next person's going to be home and sick. So look at that as a chronic pain behavior. That behavior is a result of the painful input, memories, sights, sounds, smells, mood. All these things will combine for how I present myself when I hurt. Marijuana disrupts some of the connections between these bad memories and the mood such that the person doesn't experience pain the same way. That's why some people just they say, hey, they don't hurt. They're so tough. They don't experience pain the same way. And what the cannabinoids do, they don't work, THC doesn't work locally. But there's a good study in Israel looking at traumatic amputation of the leg, did functional PET scans, found disruptions in parts of the brain that you would expect to be disrupted if you were going to disrupt this pain behavior, this pain presentation. You know, people that they sigh with everything, and some people smile with everything. That's how we present ourselves, and that can be disrupted by THC in the brain, such that people experience less pain without the opiates, without ending up in the heroin mess we're in. And, you know, I get that people could feel very guilty-ish and like, how did we miss this opiate thing? We don't want to miss it again. I agree. So let's start turning our attention to meth and coke because they're coming back. But as far as marijuana goes, it won't be an opiate thing. It won't be a meth thing.
What I'm getting at, so do you rub it on your forehead? Where do you
Well,
rub
if you
it?
have a cream, it's like any other patch. If you had a nicotine patch, they say put it on a non-hairy part of your body. You don't need to put it near your lungs or anything.
Right.
So if you have a cream, you just rub it on a non-hairy part of your body like any other cream.
So, right, but so you're not treating the body part that's giving you pain. You're basically getting it into your system so it eventually get to your brain and interrupt some of the receptors. So you're trying.
Yes, sir.
The method of ingestion is not oral. It's just tactily through some non-hairy part of your body.
Yeah, if with a cream, you could swallow it, you could rub it in, or you can use the lungs as a delivery system. Those are the three delivery systems.
What's the medical definition of analgesic?
Absence of pain. Analgesic is diminished pain. So
And none of this,
there's not a,
this interception, these nerve center interceptions, none of that's acute.
no, acute pain is a totally different thing.
Okay.
You break someone's foot, they're experiencing, when the leg is blown off, it's a completely different experience, or surgically removed for amputation will be less graphic. That's different than the phantom pain they have months later. And the neuropathy pain. I had my lung removed. I have terrible rib pain. The surgery's 8 years old. It's got to be a completely different mechanism. And my response to that pain is going to be different than the next person's response to that pain because of who my life experiences. So if you're having a chronic pain issue, if you got bad diabetic neuropathy and you can't get around, and Lyrica made you want to kill yourself, just like they say on TV, I want to take Percocets, my feet hurt so bad I can't sleep. What are you supposed to tell the patient? Let's not try medical marijuana because some kid might smoke too much weed and get schizophrenic. It's conflating again. So I'll start listening to you.
No. So the pharmaceuticals companies have been able to put drugs into, so this can't be encapsulated dry. This is if this oil, we're talking about oil.
Yes, sir.
If it were to be delivered orally outside of this, the ingestion is not through some food product.
Mm-hmm.
It's through a gel cap. And that is cost prohibitive.
Yeah, that's tough. I've seen those in dispensaries in Canada. Wherever I go to a dispensary to look around. I don't have a medical card, and those caps just eventually they're wet and they get it doesn't work so good. You can't put it. It's not a crystalline powder, so you can't put it in a capsule. I mean, in a tablet. So you could have drops. I mean, it doesn't have to be in gelatin or on broccoli.
Or what are you going to do with the drop? Under the tongue?
Yeah, under the tongue or swallow it. It doesn't have to get it under the tongue. It's perfectly well absorbed to the gastrointestinal tract.
If you are a proponent as a psychiatrist. If a proponent as a gastroenterologist came here, he would advise, it doesn't matter what your practice is, what is, in your professional opinion, the best delivery? Both from measurement and that's all inclusive of.
I would prefer oral delivery myself. because I think it will take care of most of the problems. People do have acute episodes. I get that. You can't do everything for everybody. Let's do the most we can for the most people. I would prefer oral, because then I know what 2.5 means compared to 5, where I don't know what 2 really deep inhales that I held one really good and the other I coughed out. I have no idea what that means. I know what 2.5 means. I know what 10 means.
So we're back to dosage. You can measure it.
Well, all the oral delivery products would have the dosage on them, according to this bill and, of course, common sense. So if you had an oral delivery product that was 10 milligrams and your doctor said, just cut it in half and cut it in half again and do it for 2 nights and call me back. Like, if you don't do that, that's on you. That's not on the doctor. That's not on the legislature. That's not on the bill. That's on the patient being irresponsible.
I understand we're saying it's going to be measured, but an example that was given earlier, well, I cut the brownie up in 4 parts and ate a quarter of it and I passed out. Is that because the brownie wasn't labeled with how much THC?
No, I love anecdotes. You can have anecdotes on both sides of the story. I have never heard of syncope, because that's what we're talking about. Fell to the floor. Didn't get sleepy. Kind of sit in the chair and nod out. Fell to the floor. I've never heard of syncope, fainting, as a side effect of marijuana, and I defy somebody to bring me a medical article
Well,
which links that.
the point is,
It's a nice
you're talking
story.
about a brownie that wasn't labeled as to how much stuff it had in it. Is that,
That wouldn't be available in South Carolina under this bill. Absolutely would not. You can't, all the oral preparations have to be labeled what they are, and when they expire, and how much is in there, and all that has to be on the label. So if someone got a brownie and they didn't know how much it was, and they cut it up into 4 pieces and take them, God bless them, they have more courage than me. I don't put things in my mouth that I don't know what it is.
That was the testimony this morning. I believe it was the gentleman from Phoenix up in Oconee talking about how the danger is with a brownie, you don't know what you're getting. And the point that I made was that under this bill, anything that's purchased at a dispensary has been labeled after being independently tested, both for purity, safe public consumption, but also for ratios of THC to CBD. So that's,
well, I guess the question then becomes, if you do away with the plant form of this, we're not going to sell this in bags, 2 ounces every 14 days, then what are we going to say is the amount that a card is good for every 14 days? I mean, is that going to turn into, how do you measure this stuff? I mean, what would be what's 2.5 mean, or what's 5 mean? 5
Well,
what?
you could, I mean, the way that it's phrased in an amendment that I'm working on, it would be distillate of the equivalent of this many ounces of cannabis. So there'd be a correlation there between what it was in leaf form, even though you're not consuming it in leaf form. Does that make sense? In other words, the distillate would be
You're
proportional.
going to have to translate it.
You'd have to have a conversion, but you would still define it probably in terms of what a distillate equivalent would be.
You know, let me just point out that a Marlboro cigarette without the filter weighs 1 gram. Source, Philip Morris. 28 grams in an ounce. 56 divided by 4 is 14. So that would not be this giant sack of marijuana cigarettes that law enforcement brought in. Look it up how much a Marlboro is. So what would 4 times a day be? That's how I prescribe Percocet for chronic pain. So if you have somebody that's eating 2 or 3 Percocets 4 times a day, they shouldn't be driving. They're not happy. Their life isn't going well. They're at extreme risk. And they even went to the extreme of smoking marijuana 4 times a day instead of the Percocet. That's a win for society. But coming in, and I've heard folks at some of these community meetings talk about 120 joints. No, 1 gram, do the math, it's 4 times a day. And that sounds like a lot for someone that doesn't use marijuana or may have used it in their youth. But if it's instead of a bunch of psych meds or instead of a bunch of opiates, it's a win. Again, these aren't healthy people. These are the sickest people. Every time you put somebody on there that has a ghost of a chance, somebody says, no, this is too many people. We need to restrict it. So we don't want to restrict it to hospice. But if you have Crohn's, you have multiple sclerosis, if you've got some of these really bad things, you've got traumatic brain injury and PTSD, you're taking lots of mind-altering stuff all day long anyway, so why not take something that may work better and less harmful?
I think the question becomes at that point is that you're talking as a physician of trying to instruct someone as to what they are going to do after they go to the dispensary and go home. But it sounds to me like the card or the law is written in such a way that if I get the card, I get up to this amount every 14 days, whether I need it or not. I can go get it. It's not, again, it's a little bit different than a doctor's prescription, which says you don't get up to whatever amount you want. You get what I prescribed you can get, and then when you run out, you get another prescription. So do you see what I'm getting at? It sounds like
It
we're
is,
just saying
because-
you can get this amount, and on the other hand, you're trying to say you're going to tell people how much to take, but they can go get this amount.
Well, and that's been the struggle, and I'll have Dr. Merlin comment on this too, but because when the South Carolina Medical Association people came in to me and said exactly that we're used to prescribing certain things with specificity, and my understanding, though, is that with cannabis, they can authorize its use. They cannot prescribe it because of its Controlled Substances Act scheduling. And so that's why, I mean, and what I've tried to do in this bill is move along that continuum. At one end, it's just simply, okay, you can have 2 ounces every 2 weeks, you're on your own. At the other end of the continuum is what physicians are used to doing, which is very precisely saying, take these number of pills these times a day, and move it as far along that continuum as I can without having those physicians violate their DEA authorizations. I mean, am I phrasing that correctly,
No,
Dr.
no,
Merlin?
you're correct. I just want to add that medicines are written PRN all the time. I want you to take one a day, but if you need more, so I'm going to write you for 50, but I only really want you to take one a day. But if you need more, I understand. We do that every day. Every day, people write for PRNs because you just don't know if what you prescribed is adequate. Now, I think it would personally be a great idea if that every dispensary was required to put up a copy of the law about how much jail time you get for distributing drugs. Why not? We don't want, it's against the law to distribute drugs. They get double the penalty. And I don't want someone getting up in court and saying, oh, I didn't know I'd get really in trouble for doing this. No one ever told me. I thought I could do whatever I want. It's not posted anywhere. So the fact that you get double penalty for distributing your medical marijuana, I hope it's triple or quadruple penalty. That's drug dealing. There's no other word for it. So you can't legislate people not to deal drugs. You can't legislate people to do right. I can't make people do right, or Lord Almighty, I would be out there trying. So you ask people to do the right thing. They do the right thing or they don't. There's a bad apple in every group. I don't think people should suffer, take medicines that might cause cancer, that are advertised might cause cancer. Can you imagine how hard these big companies fought not to say all the things they list at the end of those commercials? Who would want to take that medicine? And if you took it and you had one of those side effects, what are you supposed to do? Suffer because somebody else may misuse a substance? My Lord, we better shut down them bars. Someone might misuse alcohol. Spirits, strong spirits, not just like the 3% beer. In the 70s, beer was 3%, but now you can get alcohol that's almost 90% alcohol. And I think that's a problem for children. And that's what we heard about marijuana. It used to be not strong, now it's stronger. Beer's not all that strong, grain alcohol is. Okay, you don't want to get drunk? Don't drink grain alcohol. I just don't understand what all that's about. It doesn't make any sense to me.
Dr. Merlin, thank you so much for being
Thank
here.
you for being so patient. I appreciate it.
Thank you, Senators, for
Mr. Chairman,
coming all the way through,
if,
both morning and afternoon sessions.
I am working on an amendment for the committee's review, work with staff on trying to incorporate a lot of the good things we heard today, and I'll be ready next Thursday to explain the bill as amended as best I can.
Appreciate that, Senator. Appreciate the work of the subcommittee. We'll look forward to hearing from you on Thursday. Nothing else before us. We'll stand adjourned.